This is Ian Crosbie, CEO of Sequana Medical, pioneers in the treatment of drug-resistant fluid overload. Fluid overload, or excess fluid in the body, is a key clinical problem in many large and growing diseases: liver disease, heart failure, kidney failure, and cancer. The standard of care is diuretics or water pills. They've been around for many years, but the problem is that many patients are no longer responsive to this therapy, and the current alternatives have significant clinical disadvantages, leading to poor clinical outcomes, major impacts on quality of life, and large costs to healthcare systems. That is why we have developed our alfapump and DSR therapies, both backed up by strong granted IP portfolios. The first, the alfapump, is focused on liver disease. This is a market that we believe will grow to over 3 billion euros a year, driven by the growth in NASH. This is changing the face of the liver cirrhosis market and driving growth of between 6 to 7% per year. The alfapump is already approved in Europe, and in the US, we have FDA breakthrough device designation. Our North American pivotal study, POSEIDON, intended to grant marketing approval, will be reporting its primary endpoint in Q4 of this year, and we have already reported important and very strong interim data from this trial. If approved, we intend to commercialize the alfapump directly in the United States through our own focused specialty sales force. The second product, DSR, is focused on heart failure, a multi-billion-dollar commercial opportunity for us. Congestion, or what fluid overload is called in heart failure, is the primary driver of morbidity and hospitalization in these patients. With our first generation drug, we have demonstrated clinical proof of concept with durable clinical benefits. We are now moving to our second generation drug, and it is that we will use with our MOJAVE study, our US study that we intend to start in the first half of 2023. Once this study is completed, we intend to establish a partnership with a major player in heart failure for future development and commercialization. We have a strong outlook of growth drivers. On liver disease, we intend to report the primary endpoint for POSEIDON before the end of this year, and then submit our PMA for approval to the FDA in the second half of 2023. In heart failure, we plan to report the top-line data for our SAHARA study before the end of this year, and then commence our MOJAVE study in the United States in the first half of next year, reporting interim data in the second half of next year, and top-line data in the first half of 2024. Now turning for more detail on our first product, the alfapump, which is focused on the treatment of liver refractory ascites. We do this with our alfapump, which is a way of pumping fluid that is concentrated in the peritoneal cavity into the bladder, where it is simply urinated away by the patient in the most convenient manner. This is a fully implanted high-tech pump intended to remain within the body for a year or two. There are no external wires or catheters. It is wirelessly charged. The settings can be changed wirelessly, and we collect the data wirelessly and remotely. The pump operates automatically and autonomously. All the patient has to do is to charge the pump up for about 20 minutes per day. We know how to put it in. We know how to keep it patent for long periods of time. This is incredibly capable, can pump up to 4 liters of biological matter per day. And we've demonstrated this with over 950 systems implanted and hundreds of patient years of experience. The disease we treat is refractory ascites, which is a key complication of liver cirrhosis. It doesn't matter how you attack the liver, whether it is with a virus, hepatitis, with alcohol, or with fat, but that can cause scarring of the liver. And this scarring is what is known as cirrhosis. One of the key functions of the liver is to clean the blood. But if it is scarred, that impedes the flow of blood through the liver, which causes the liver to leak a plasma-type fluid. And these patients can lose maybe a liter of this fluid per day. The fluid builds up in their peritoneal cavity, the bag that contains many of your organs, and it has nowhere to go, so it accumulates. So in this slide, you can see the the huge swelling that can develop from this accumulation. Standard of care is drainage. So once drained, the patients will have several days of relatively normal life where they have little fluid accumulated. Then the fluid will build up, making it harder to eat, sleep, breathe. They'll feel constipated and nauseous. Then as more fluid builds up, it becomes very hard to remain upright. If they fall over, they can't get up. It's very difficult to breathe. They can hardly eat. They are vomiting. They are constipated. And then they go to hospital to be drained, and it starts again. So as you can see, a terrible life and prospect for these patients. With the growth in NASH in North America, we see a market of around 150,000 patients over the next 15 to 20 years per year. As I mentioned earlier, NASH is transforming the profile of liver cirrhosis. It is going from a market that was traditionally dominated by alcohol and viral hepatitis to one that will be increasingly dominated by NASH. And with obesity being the primary driver of NASH and the US being ahead of Europe in the profile of obesity in the time to development here, we see the US as being the most important market for us here. And we also see it as the market which is going to take liver cirrhosis from a disease that has been ignored for many years to one which is a mainstream disease that requires 21st century solutions. And that is why we believe we have FDA breakthrough device designation. Because this disease has not been focused on for many years, there are limited innovation in the space. The standard of care is drainage. This was in fact invented by the ancient Egyptians and hasn't changed much since. You let the patients build up 10 to 15 liters of fluid in their abdominal cavity, you bring them into hospital and you drain them over the course of 5 to 7 hours. It has to be done under medical supervision because of the cardiovascular impact of draining this much fluid. As you can imagine, it's painful, very poor quality of life for the patient, large burden, and the benefit is very short term. As soon as they leave hospital, the fluid starts to accumulate, a terrible outcome. And this is not a cheap procedure in itself. We estimate that the cost in the US is about $1,500 to $1,800 per drainage. So while an individual therapy is relatively inexpensive, over 15 to 18 months, the cost will build up significantly. You can put in a permanent external drain. The problem with this is it can lead to blockage or a source of infections. Patients are already immunocompromised, and in many cases, they don't like the stigma of having this permanent external drain. It's very good for patients with limited life expectancy of, say, 3 to 6 months. But beyond that, we see the need for a less intrusive system. About 20 to 30 years ago, doctors came up with the idea of doing a bypass for the liver. So you have what's called a TIPS. This is effectively a covered shunt, that enables the blood to flow through the liver with limited resistance. It's a very good job at reducing the resistance, but the key problem is it reduces the blood flow through the liver, and the liver has less opportunity to do one of its key roles of cleaning the blood. This leads to a buildup of toxins within the blood, particularly the ammonias, which can lead to mental side effects, hepatic encephalopathy. It is also contraindicated in patients with heart failure. Hepatic encephalopathy, the risk in the 50s is around 30%, but above 65, the risk increases dramatically to over 70%. So while we believe TIPS is a very good option for younger, fitter patients, we believe there are severe disadvantages in the older population, which is where we believe NASH is driving the market, both because of the HE risk, but also this contraindication to heart failure, which will be a problem in many NASH patients. Finally, there is liver transplantation, which is the only cure out there for this disease. However, there is a major shortage of organs and it is a high cost. It's estimated over $1 million per patient here. So we see the alpha pump actually working in partnership with liver transplantation, either as a bridge to therapy, keeping patients mentally and physically fit, ready for their high cost and scarce procedure, or providing a destination therapy for those patients that cannot be put onto the transplant list and need better options for their remaining life. So as you see on this slide, this is how the alpha pump is implanted. The alpha pump goes below the rib cage on the right-hand side into a pump pocket, just like a defibrillator. One incision on the midline for the catheter into the peritoneal cavity, one incision over the bladder for the insertion of the bladder catheter. Then the catheters are tunneled under the skin back up to the pump pocket for the alpha pump. Procedure takes between 45 and 60 minutes by an interventional radiologist. Then all the patient has to do is to simply charge it each day for about 20 minutes with a handheld smart charger. And each time the pump is charged, we collect the data and that gets sent back to us for analysis. And we then send a regular report to clinicians. We are in various European guidelines, including EASL and DGVS. But most importantly, we have FDA breakthrough device designation. We are currently in our North American pivotal study, the POSEIDON study. It's a very straightforward study design. What we do is we take patients on standard of care, external drainage, and we follow them for 3 months to see how often they are drained and how much fluid is removed from these patients. Then the alpha pump is inserted, and the patient has 3 months to get used to working with the pump and let it settle down. Then the patients are again followed from month 4 to month 6 post-implantation to see how much external fluid there is and how often they need to be drained. And what we do for the primary endpoint of the study is to compare the post-implant period to the pre-implant period. And the primary efficacy endpoint for the study is a 50% reduction in the average rate of external drainage and a responder analysis where looking for 50% of patients to have a 50% reduction in the rate of external drainage. There's also a primary safety endpoint in terms of reinterventions, and then various secondary endpoints, including quality of life, health economics, safety, and survival. There are two cohorts of patients in this study. There is the pivotal cohort of 40 patients, the ones that will be evaluated for the efficacy endpoint. But there is a second group, the roll-in or training cohort of 29 patients that are used to familiarize and train centers with the alpha pump before they perform their pivotal cohort here. Because the rolling cohort is not part of the efficacy endpoint, we are allowed to report on that cohort early. And it is that data that we've already reported on. This interim data on 26 of the roll-in patients demonstrated very positive primary endpoint signals. In terms of efficacy, there was more than a 90% reduction in the rate of external drainage versus a target of 50%. All of our patients had a 50% reduction versus the 50% target here. So very strong outcomes on the primary efficacy endpoint. Safety was in line with expectation, and quality of life demonstrated clinically important improvements very quickly at 1 month and then continued even out to 12 months post-implantation. We also looked at survival on these patients as well. And as you see on this trace here, there is about 70% survival at 12 months post-implantation. If we compare this to the data presented in the AASLD practice guidelines, they talk about a survival rate of only 50% at 12 months. So while this is not a direct head-to-head comparison, we believe it gives a very favorable profile for the alpha pump as we move forward. In terms of timelines, we have completed all of the implants in the study, and we are now preparing for the primary endpoint readout in Q4 of this year. Then we'll be submitting the PMA to the FDA for approval in Q4 of 2023, and we look forward to approval and then launch in second half of 2024. In parallel to that, we'll be starting our US commercialization preparations. There are existing ICD-10 and DRG codes relevant to the alpha pump that we believe will support initial commercial launch. And in addition to that, we will have the benefit of NTAP for breakthrough devices that we believe will lead to higher reimbursement while we generate real-world data from patients in the United States that we hope will lead to higher reimbursement going forward. We intend to commercialize the alpha pump directly in the United States through our own specialty sales force. We can do this because the practice guidelines in the United States say that any patient who starts having ascites has to be referred for a liver transplant and has to be referred to one of these 140 liver transplant centers. And it is by focusing on these liver transplant centers that we can see the large flow of these patients in a very effective and very efficient manner. We believe that we can target the top half of these 140 transplant centers with a sales force of about 50 initially, and then we can scale that up to cover all 140 of these centers. So we look forward to building this sales force and targeting this highly focused and very dynamic market. Now moving ahead to DSR, our disease-modifying heart failure drug therapy, the second of our proprietary therapies. Congestion is a major problem in heart failure. While you may think that the patient clutching their chest or unable to walk down the street is the major cause of hospitalizations in heart failure, that is not the case. Of the 1 million hospitalizations each year in the United States due to heart failure, 90% are due to symptoms of fluid overload. 3/4 of them come to the emergency room with blue lights. Typical length of stay is 5 days. And the cost for all of these hospitalizations is around $13 billion a year. It is one of the largest costs for Medicare in the over 65s. The reason for this is because many patients no longer respond to even the strongest form of the drugs, the so-called intravenous loop diuretics. And this leads to 1 in 4 of these patients returning to hospital within 30 days of discharge. So it's very clear that the current treatment for these patients is not effective and a better treatment option is required. That is why we developed DSR, the direct sodium removal system, where we work in partnership with the kidneys to eliminate fluid that is not concentrated in any one particular place, but is spread all across the body. Everybody listening to this call today will have a similar level of sodium concentration in their bloodstream, about 135 millimoles per liter. The problem is, in heart failure, the body responds by accumulating sodium and therefore has to accumulate fluid to maintain that concentration in the bloodstream. And this fluid accumulation causes swelling all over the body, the arms, the legs, the necks, and the thorax, which often causes that fluid overload in the lungs that causes patients to feel they are drowning. What we seek to do is to remove that sodium buildup in the body, forcing the kidneys to eliminate the excess fluid to maintain that sodium balance and therefore reducing the fluid overload. In the first picture here, you see a fluid overloaded patient. The blue dots are the water, the red dots are the sodium. We put a sodium-free treatment drug into the peritoneal cavity. By simple diffusion, the high concentration of sodium in the bloodstream and the low concentration of sodium in the DSR drug causes sodium to move from the bloodstream into the DSR drug, causing a buildup of, say, 5 to 10 grams of sodium in the DSR drug in the peritoneal cavity. We then remove that DSR drug with all that accumulated sodium from the body, causing the removal of, say, 5 to 10 grams of sodium from the body, resulting in excess fluid within the body. The kidneys are then forced to step in and do the only thing they know to restore balance, which is to eliminate the free water, bringing the body back into balance and also reducing the fluid overload. A very simple concept, but one which we have fundamental patents granted on the use of low or no sodium drugs to reduce fluid overload. This is now granted in the US and Europe. We have done several studies with repeated dose DSR therapy with very good results. The first was the Red Desert study, where we worked in heart failure patients on high doses of drugs, but they were not fluid overloaded. They were at the correct level of fluid. We did this in our first study to make sure that we could get plenty of experience with DSR administrations. And what we did here is we stopped these high doses of diuretics in these patients and replaced it with DSR therapy up to 3 times a week for 6 weeks. And what we showed here was that DSR therapy was highly effective at managing the fluid and sodium balance with no clinically relevant hyponatremia. What we were very excited to see was there was a strong improvement in the health of the heart as measured by natriuretic peptides, a 30% decrease. We also saw an improvement in the health of the kidney as measured by an increase in EGFR. Once the study had finished, patients then had to return to normal therapy because obviously their heart failure remained. But what we saw is that over the course of the therapy, the kidney had become diuretically normal again. It responded to diuretics just like as if it was a normal kidney. And as a result of this, we did not see any congestion-related rehospitalizations during the course of the study. That gave us confidence to move on to the Sahara study. We were now working with the same diuretic-resistant heart failure patients, but this time we were working in decompensated patients, patients who had fluid overload that was not responding to these high doses of diuretics. And this time we were working on giving these patients more intensive DSR therapy and seeing how quickly we could remove that accumulated fluid and how quickly we could restore their cardio-renal health. And now we saw that we could safely, effectively, and rapidly eliminate this persistent congestion or extra fluid. And we were seeing a loss of around 6 kilograms or 15 pounds in the first week of treatment here. And we did this with no clinically relevant hyponatremia or change in electrolytes. Again, we saw considerable benefit in their cardio-renal status, the health of the heart and the health of the kidney. Again, we saw a 30% reduction in natriuretic peptides, a measure of heart failure. And here we saw a stable kidney function, which we believe is a very good outcome considering the amount of fluid that had been removed from these patients. And again, over the course of therapy, we saw the kidney go from being diuretic resistant to diuretically normal over the course of the treatment here. And once more, there was no congestion-related rehospitalizations for these patients over the course of the therapy. What was very exciting in both of these studies that once we finished the studies, we continued to follow these patients. And when we initially started this study, we thought that the resistance of the kidneys to diuretics would return very quickly. But what we saw is that was not the case. And we saw the doses of diuretics these patients were on before they started therapy to after they were on therapy reduce and stay low. The top half of this slide is the red desert patients that we've been following for about 23 months. And the bottom half is the Sahara patients that we've been following for up to around 1 year. As you can see, there are very significant reductions in their needs for loop diuretics. This in itself is not a major importance to reduce the dose of the drugs because they are cheap and easy to come by. But what this shows is a sustained improvement in the cardio-renal health of these patients. And because they are now healthier, have a healthier heart and a healthier kidney, these patients are fundamentally improving in their heart disease. And that is why we believe we have a disease-modifying heart failure therapy. If you combine the data we have from Sahara and Red Desert, so we saw this improvement in natriuretic peptides, this dramatic reduction in loop diuretic needs, and the one-class improvement in NIA status, New York Heart Association status, you can put all of those clinical points into the Seattle heart failure model. This is the most validated model of predicted survival in heart failure patients. And what we see is we compared our patients before DSR therapy to after DSR therapy. And we see a 75% reduction in predicted mortality for these patients post-DSR therapy versus pre-DSR therapy. So this is hugely exciting, as well as this elimination of hospitalizations during the course of the study. We also see this strong improvement in predicted outcomes, which makes us excited about the fact that we are fundamentally tackling the heart failure of these patients in a way that is not possible today. Studies to date have been conducted with DSR 1.0, our first generation proof of concept drug. This was enabled us to get very rapid clinical proof of concept and a very rapid clinical path. However, it is not the easiest drug to use. It does not have the best perceived safety profile. So going forward, we will be moving on to DSR 2.0, which is a sodium-free combination of dextrose and icodextrin. Icodextrin has been used for many years in the renal failure market, but has never been available and is not available in a sodium-free formulation, so is highly proprietary. This, we believe, will give a better therapeutic profile and a better safety profile. We will be able to remove more sodium over a longer period of time, causing a longer, slower movement of sodium from the body that will make it easier to use and much more straightforward in the broader clinical community. We have a very strong granted IP position already in the US and Europe, which will enable this DSR drug to be a recurring revenue stream of very high gross margin in line with drugs. It is this that we intend to move forward into the MOJAVE study, and we are currently conducting CMC and safety work to support that trial. So as you see, in terms of status, Sahara is now looking to complete and report the top-line data by the end of this year. For DSR 2.0, we are completing our CMC and our animal safety work. We're then looking to combine that data into an IND filing with the FDA to support a start of the MOJAVE study in the first half of next year. This is intended to be a phase 1b, 2a study with US patients, approximately 30 patients in a randomized controlled multi-center study. And it is the data from that trial, the MOJAVE trial, that we intend to use to establish a partnership for future clinical development and ultimately commercialization. In terms of commercial potential, it's hard to put an exact number on this today as we explore the real survival potential of DSR moving forward. But it's already clear that there are about 400,000 heart failure patients hospitalized per year in the US and EU routinely. The so-called frequent flyers, these patients do not respond effectively to current therapies, becoming a high-cost burden on healthcare systems, payers, and a major impact on the quality of life and clinical outcomes for these patients. If we just look at a reduction in hospitalization costs for these patients, it's approximately $40,000 per year. But on top of that, there is clearly the expected increase in survival for these patients. So we see the ability to secure a very valuable pricing for the DSR drug as we move towards the market. So in terms of future drivers, just reiterating what I shared with you earlier, for liver disease, primary endpoint readout in Q4 of this year, PMA submission in the second half of 2023. In heart failure, top-line results of our Sahara study in the second half of this year, then getting our US MOJAVE study underway in the first half of next year, interim data the second half of next year, and then top-line data in the first half of 2024. So I hope you agree from this presentation, you'll see we are very strongly positioned for growth in our two key markets. First of all, in alfapump and liver disease, a market that is growing very strongly with unique positioning as NASH changes the profile of the liver cirrhosis market. Reporting data of our North American pivotal study before the end of this year, a study we have already de-risked with the interim data, and we look forward to commercializing this through our own focused sales force in those 140 liver transplant centers. Heart failure with DSR is a multi-billion opportunity. Tackling this issue of congestion in these diuretic-resistant patients is a key challenge for clinicians today with limited clinical options. We've already demonstrated clinical proof of concept as a heart failure disease-modifying drug therapy. We are now moving on to our proprietary DSR 2.0, which will provide a better therapeutic profile with strong IP protection driving recurring high margin revenue. And we look forward to establishing a partnership with a major heart failure player on the back of a MOJAVE 1B/2A study in the United States. Thank you very much.